cyst, B. endometrioma, C. dermoid cyst, D. tubal ovarian abscess. So the answer here is an endometrioma. A chocolate cyst is the one that shows homogeneous low level.
In a good life one.
Question number 2. A pelvic mass demonstrates highly echogenic mural nodule, posterior acoustic shadowing, echogenic lines and dots, fat fluid levels. What is the diagnosis? A. serous cyst adenoma, B. dermoid cyst, C. hemorrhagic cyst, and D. endometrioma. This is a pelvic mass with a highly echogenic mural nodule that portrays a posterior acoustic shadows.
So in this case presentation, I am going to present you with the images that I did.
Cyst. So the
then
echogenic mural nodule,
I need you to
nodule, and the fat fluid
come up with a diagnosis.
Mesh.
So you can team up as groups, you can be individuals. So I need you to come up with a diagnosis. So write in the comment section. Let's discuss in the comment section
answer is B.
On our YouTube channel. Let's exhaust.
Question number 3.
After
I will
then give you the answers.
Yes.
So this is a new
irregular endometrium
quiz where we give real life cases. So I've just done this case today. So let's see the
junction poorly defined.
I need you to come up. Then I'll give you the history after I have shown you the images. Then I need you to come up with the diagnosis or the differential. What you call it.
D. submucosal fibroid. So our keywords there are.
So there we go. What we have here, guys, what we have here, we do have got the carotid. This is the carotid. Carotid, the right carotid artery there. Then if you look down here, you can see there's a bulb there that is bulging, the bulb that is bulging there. I hope that you are seeing it. Down there is the bulge, there's a bulge there, and this is the carotid. That's the right carotid. I wanted to look carefully what is going on
here. Our answer
so I need you guys to start to brainstorm.
Question number 4.
To patient presents severe So this is the carotid going all the way like that.
Peripheral
for the base of the carotid, that's what you are
minimum venous flow, no arterial flow,
a number
and the
of images and videos that I have acquired. So in this presentation, I'm just giving the video so that you can appreciate in real time what was going on. Then you can come up with a diagnosis. So let me go to the next video.
Ultrasound demonstrates
what
the large ovaries, 9 centimeters, peripheral follicles, minimum venous flow, no arterial flow, and so the key words.
So here,
no arterial flow, let's see the colorful signs. So this is
so you see on color Doppler,
ovarian tones. So the purple sign,
look at what is happening.
the characteristic sign, ovarian tones.
Guys,
question number 5. Ultrasound results before inoculate annexia mass.
Think of, I need the brain, I need the clever sonographers, I need the clever radiologists. This is very exciting. So let us make it interactive.
Ultrasound results before inoculate
possible
annexia mass.
I need the brain.
So
this is the most exciting part of our
internal vascularity,
where we the real. And now I'm going to give you the real cases that I am doing in my class. I show you the carcinoma, come up with the diagnosis. Look at what do you think this is?
So if you see
what do you think this is?
ovarian mass that is multiloculated with the papillary projections and internal vascularity, these are typical transformation.
So now,
this is
so in terms of
epithelial
can you see what is
carcinoma, which is C. If you see a cyst adenoma, is benign. You don't see papillary projections. You don't see internal vascularity.
Is this minor?
Also, serous carcinoma is benign. The fluid
If it's
contains
abnormal,
and the
what is that abnormal?
and the hydrocephalus.
If it's normal,
Now
what is that
that's the
normal?
fluid collection
So,
in the fallopian tubes.
this is the right side of the neck, and you can see here.
Question number 6. A patient
What is
presents
this and what
with
is going on
heavy
there?
menstrual bleeding.
Okay.
Ultrasound demonstrates globular uterus, heterogeneous myelitium, fan-shaped shadowing, myometrial.
Question number 6. Another
junction
video again.
What's the diagnosis?
This one, you see now the color Doppler, you can see here, you can see
Adenoma,
nice, you can see how it looks color. Look at that.
leiomyosarcoma.
So initially when I saw, I was thinking that there is sort of a shunting that is happening. I was like, I didn't understand that is happening between the carotid shadowing and the jugular vein. So, but when color, you can see that
So the globular structured uterus with the heterogeneous
what is this, guys? What are we looking
shaped?
What shadowing means the pregnant
Characteristics
people can see this is now real ultrasound. Hear me, people, radiologists, the clever sonographers,
so with
the competent radiographers, let's gather here with these guys. Let's gather here. What are we doing? I've given you a hint of the jugular vein and the jugular vein. I don't know. This is the jugular vein. I am not sure. So that's up to you. To make what is going on there.
Question number 7.
We're going to say this configuration is normal. It's your answer. We say this. What is that? The waist sign. You're doing your sonar in the department. Then you see what is it?
Vascularity. What is that? A. Question number 4. Ovarian cyst. B. Hydrocephalus. C. Ovarian cyst. So this is a big circle.
Let's play another one.
Now look at this. Look at hydrocephalus.
Look at what is going on.
That's ecology. What is
Let's play the longitudinal section of the carotid
internal vascularity.
Are you seeing nicely, you guys?
Question number 8. A first trimester pregnancy has empty uterus, adnexial vesical sac, live embryo with cardiac activity, more than 3 fluid. Question number 8. The pelvis. A first trimester pregnant woman has empty uterus, adnexial gestational sac, live embryo with cardiac activity. More than 3 fluid.
Look what
What is the diagnosis? A. Pregnancy of
I need to
location. B. Ectopic pregnancy. C. Tubal pregnancy. D. Corpus luteum. Now, empty uterus.
Let's do it.
Adnexial gestational sac.
Look
Live embryo activity. More than 3 fluid in the pelvic region. So the answer is tubal ectopic pregnancy. The ectopic pregnancy is a pregnancy where there is coexistence of a normal intrauterine pregnancy and an ectopic pregnancy. So in this case, our uterus is empty, so it can only be tubal ectopic pregnancy. Question number 9. A large uterine mass demonstrates rapid interval growth, irregular margins, marked central vascularity, areas of necrosis. What's the most likely diagnosis? Question number 9. Endometrial fibroids. B. Leiomyoma. C. Leiomyosarcoma. D. Adenomyosis. What are the key words? It's a rapid interval growth of the mass, irregular margins, marked central vascularity, and areas of necrosis. So a rapidly growing mass with the central vascularity and areas of necrosis is in keeping with leiomyosarcoma. So that is now a cancer. So a fibroid can transform into a cancer. So when that happens, it's now called a leiomyosarcoma. So the correct answer for this question is leiomyosarcoma. Question number 10 in our last question. A woman undergoing infertility woke up with ultrasound findings of 2 separate endometrial.
So in this case presentation,
deep
I
external
am going to
fold cleft
present you
above 1
with the
centimeter.
images
Widely
that I
divergent.
just
Question number 10 is what is the
then
most likely diagnosis?
I need you to
accepted uterus. B,
come up with a diagnosis. So in this case, you can team up as groups, you can be individuals. So I need you to come up to the diagnosis. So right in the comment section, let's discuss in the comment section on our YouTube channel.
So there is a
Let's exhaust it there.
kind of cleft
After
above
that,
us.
I
So
will
this
get you
is
the answer.
consistent with
So
a
this is
biconway uterus. With a biconway uterus. Ladies and gentlemen, this marks the end of our expert quiz daily challenge, answer and explanation discussion. I hope you're doing very well. Let's meet again tomorrow with the second quiz. Then we can tackle that. Then we'll discuss the answers again. I hope learning is gradually taking place. Enjoy the rest of the day. Don't forget to subscribe to our channel, share, like, and comment.
Good day, everyone, and welcome back to Medical Ultrasound Academy. Today's case is one of the rarest and most fascinating conditions ever reported in medical imaging. It is so uncommon that many radiologists, sonographers, and gynecologists may never encounter a single case throughout their entire careers. Imagine a woman who became pregnant, lost the pregnancy decades ago, and unknowingly carried the remains inside the abdomen more than 35 years. Instead of being expelled or absorbed by the body, the fetus gradually become converted into calcium, creating what is known as lithopedion or the stone baby. At first glance, this patient simply presented with chronic abdominal discomfort and a pelvic mass. However, as the ultrasound probe was placed on the abdomen, in an astonishing picture, what initially appeared to be a calcified mass slowly revealed recognizable fetal bones, including the spine and long bones. The ultrasound findings immediately raised one of the most extraordinary differential diagnoses. In today's presentation, for this remarkable case step by step, we will review the patient's clinical history, analyze the ultrasound findings in detail, compare them with X-ray, CT, and MRI appearances, discuss the differential diagnosis, explain how the diagnosis learning points that every ultrasound professional should know. I also have a challenge for you before I reveal the final diagnosis. I want you to carefully study the images and tell me in the comments what you think this lesion is. Could you diagnose this rare condition before seeing the CT scan? Let's find out together. If you are passionate about mastering ultrasound learning from real-world class that sharpen your diagnosis skills, make sure you have subscribed to Medical Ultrasound Academy, turn on notifications, and join our growing community of imaging professionals. So let's go straight into the case. So this is a very fascinating presentation and a very fascinating case that I have never seen before in the history of my career. So fasten your belts and then let's get to business. So this is the case of the week, the baby that turned to stone, which is called a lithopedion. So you can see here, this is the CT image. You can see here, there's the head of the fetus, and you can see here, these are the hands, this is the body, as you can see here in the pelvis lady. So you can see after extracted, you can see that these are the human remains. These are the human remains. So this is the hook. 88-year-old woman presented with abdominal discomfort. What doctor discovered inside the abdomen stunned everyone. She had been carrying a dead fetus for more than 35 years. Look at that, look at that. So, a lithopedion is a rare medical phenomenon which an unborn fetus dies during an abdominal ectopic pregnancy and it's too light to be reabsorbed by the body, calcifies into a stone baby. So it comes into a stone baby. So the clinical case. So a patient, age 68, gravida 5 para 4, chief complaint, chronic low abdominal pain, progressive abdominal fullness, occasional constipation,
difficult walking due to pelvic discomfort. So the history, the patient reported being pregnant approximately 35 years ago while living in a remote rural area with no access to medical care. So she experienced severe abdominal pain during the second trimester, followed by cesarean section, cessation of fetal movements. She never sought medical attention and believed she had lost the baby. Over her decades, the abdominal swelling remained stable, causing only intermittent discomfort. No vaginal bleeding. Okay, so you can see here on this X-ray what we have here, what we have here. So the examination. Blood pressure was normal, febrile, had irregular pelvic mass, portable, non-tender, uterus difficult to define separately. So the laboratory test, CBC normal, CRP normal, pregnancy test negative, renal function normal. So the ultrasound findings, look at what is here, look at what is here, look at what is there. You can see here the fetal remains, you can see here on X-ray what we have. So grayscale heterogeneous pelvic mass, cardiac activity was noted, no abdominal fluid was demonstrated. So the color Doppler demonstrated no vascular identification. The uterus is displaced, but otherwise unremarkable. No free pelvic fluid. So the impression. So the clinical case. A large chronic extra-uterine calcified fetus, which is called the lipopedion. Findings are highly characteristic of an advanced abdominal ectopic pregnancy with complete fetal calcification. Recommend CT scan for surgical planning. So when you see such a case, you should also recommend the CT so that you can plan for surgical management and then you can localize it nicely. So these are the stunning X-rays you can see. You can see here fetus there. So that is how an calcified obstetrician fetus appear like on X-ray. You can see how it appears like on X-ray. It appears exactly like this. So the X-ray shows complete fetal skeleton, calcified skull, vertebral column, femurs, the ribs, abdominal fetal line, abnormal fetal line, dense calcified surrounding the fetus, which is the diagnosis. What is blood pressure? As a what? That's a what? That's a what? Have you ever seen such a case in your life? Have you ever heard about it? Have you read about it? Or it's the first time? I'm asking you, the medical community, the sonographer community, the radiology community. What's the take? Have you ever seen this? So the ultrasound findings, years of experience and work. So here are the CT findings. You can see here what we have there, what we have the calcified lipopedion there. You can see what they can see there. So CT demonstrates completely calcified fetus, preserved fetal anatomy, calcified placenta, no surrounding inflammatory changes noted, displacement of bowel loops, chronic adhesions. 3D reconstruction beautifully demonstrated the fetal skeleton. So you can see here on 3D reconstruction, you can see here the fetal skeleton there nicely. MRI. So MRI is really required, but may show segment void from calcification, relationship to bowel adhesions, so in this case, we don't have the images for the MRI. It was not necessary because we have got all the information. So these are the stunning. So you know, when you are doing radiology or practicing radiology, you must also appreciate the role of other imaging modalities, and you must know at what extent that some modalities might not be necessary. So in this case, we have made a diagnosis already. So it's not necessary to unnecessary expense to the patient. So the final diagnosis, that's a little period to the stone baby. So it's called a stone baby. A rare complication of an abdominal ectopic pregnancy in which the deceased fetus becomes calcified because it is too large to be reabsorbed by the mother's body. So it remains for years. So what are the differential diagnoses for a little period? Calcified uterine fibroid, pure cystic ovarian teratoma, calcified ovarian neoplasm, calcified mesenteric cyst, chronic tubal ovarian. So here are the CT findings. So the management of a little period. How do we manage a little period? How is it managed? So CT evaluation, multidisciplinary assessment, then conservative management in selected elderly asymptomatic patients. So if someone is old, there's no need to bother them with it. There's no need for surgical intervention. If there are no symptoms, you can just let it go like that. So laparotomy is if symptomatic or complications develop. So at times it can be associated with pains and all that. So in that case, then you need to reduce the pain. That's where you operate and remove the lithopedion. So what are the learning points in this case? So the learning point, the take home. So lithopedion is extremely rare, estimated incidence around 0.0054% of all pregnancies. It results from abdominal ectopic pregnancy where the fetus dies after the first trimester and is not fully absorbed. So the body deposits calcium around the fetus to protect against infection. So you see how the body is self-preservatory method. So it disposes calcium around the baby so that it doesn't cause, because the baby is a foreign body, it causes inflammation around the surrounding tissues. Many patients remain asymptomatic for decades before diagnosis. So it is the best imaging modality for defining anatomy before surgery, while ultrasound is often the first imaging test to raise suspicion. Ladies and gentlemen, this is one of the most fascinating cases ever. I hope or I wish you can see such, or don't miss it in future. For the final diagnosis, so let it be at the back of your mind that I might see a case of with scanning these old postmenopausal ladies. Thank you so much for your time, ladies and gentlemen. Let's meet again in the next segment of our case discussions. Thank you so much. Don't forget to like and share. Enjoy the rest of the day. Bye. Body, ultrasound mystery case. Meninges disease. Is it a benign tumor or is advanced ovarian cancer? What's your take? So these are ultrasound images for a case in question. We have got an ovary here, then we've got a tumor here, there is a mass there, there is a fibroma here in the ovary there, and you can see here there is ascites around the uterus. That's the bladder there. There is ascites there. That's the uterus and the ascites. You can see that the uterus is floating in ascites. You can see ascites there. Then there, all of that is ascites. So on X-ray, so you can see on X-ray there, there is pleural effusion there. There is right pleural effusion, right-sided pleural effusion. So here's the clinical TSA. On the case in question, a 56-year-old, that's the history, postmenopausal woman presents with progressive abdominal distension, shortness of breath, pelvic discomfort, unintentional weight gain, elevated CA125. Ultrasound reveals a large solid adnexal mass with massive ascites. The question is this advanced ovarian cancer or something else completely benign? That's the challenge now. That's the TSA. How do we go about it? How do we navigate when we see such a case in our department? Now, let's go to the comprehensive ultrasound report. Examination, pelvic ultrasound, transabdominal and transvaginal was done. So the clinical history, Postmenopausal female with increasing abdominal swelling, dyspnea, and suspected ovarian lesion malignancy. So you can see the abdominal distension there. Ultrasound findings: the uterus, antevated uterus, normal size, endometrium measures 4 millimeters, no focal uterine masses are identified, right adnexia, a large, well-defined, predominantly solid ovarian mass identified. The measurements: 11.8 by 9.5 by 8.7 centimeters. Characteristics: homogeneous, hypoechoic echo texture, mild posterior acoustic attenuation, lobulated but smooth external margins, minimum internal vasculature color Doppler, no papillary projections are noted, no cystic degeneration, no calcification. The appearance is highly suggestive of an ovarian fibroma or fibropecoma. So the left ovary, normal appearance, measures 3.0 by 1.9 by 2.0 centimeters with normal vascularity. Ascites, large volume, free intraperitoneal fluid is present involving the pelvis, the paracolligators, the Morrison's pouch, perisplenic space. Fluid appears simple without septations or internal echoes. So the Doppler assessment: minimal vascularity within the solid lesion, ovarian lesion, no evidence of torsion. Additional findings: no enlarged pelvic lymph nodes, no peritoneal nodules identified, no omental cells demonstrated sonographically. So suggested additional imaging: because of the associated dyspnea, chest X-ray, CT chest. These demonstrate moderate right pleural effusion. Differential diagnosis that you can have: ovarian fibroma, fibropecoma, renal tumor, pedangulated uterine fibroid, ovarian carcinoma, and metastatic ovarian tumor. These are the common differentials for Meninge's disease. Why it mimics cancer? The combination of large solid ovarian tumor, massive ascites, right pleural effusion, and elevated CA125 can strongly resemble stage 3 ovarian cancer. So this is one of the most confusing cases. So you must appreciate and understand that when you are dealing with Meninge's disease, you must have so the clinical history: the ovarian tumor, you must have ascites, you must also have right ascites pleural effusion. So if there is the ascites and there is the ovarian tumor without ultrasound findings, right pleural effusion, now it's pseudo Meninge's disease. It will be pseudo Meninge's. So the final ultrasound impression: right adnexia, large solid right ovarian mass demonstrating imaging features most consistent with an ovarian fibroma or fibropecoma. Characteristics: associated large volume simple ascites. Clinical history of pleural effusion raises the possibility of Meninge syndrome. No convincing sonographic evidence of peritoneal metastatic disease. Recommend gynecological oncology referral and histopathological confirmation. So it's not simple or it's not easy for you to quickly rush and say that this is Meninge's disease simply on ultrasound or based on ultrasound findings alone. Otherwise, so the left ovarian cancer as well. So you must recommend gynecological oncology referral and histopathological confirmation. So let's define this. What is Meninge's disease? So Meninge's syndrome is the triad of benign ovarian fibroma, which is the fibrotecoma or tecoma. That's the ovarian mass that we are talking about. So the Doppler assessment, you should have ascites and you also have right pleural effusion. So if one of those is missing, additional is no longer Meninge's disease, can be pseudo Meninge's disease. So the triad of benign ovarian fibroma, so suggested additional or tecoma, ascites in the pleural effusion. The ascites in pleural effusion typically resolve after surgical removal of the ovarian tumor. So the classic ultrasound feature appearance, the tumor, solid ovarian mass, the echogenicity, homogeneously hypoechoic, margins small, well circumscribed, minimal vascularity, ascites, usually large volume, metastasis absent, peritoneal implants absent. So why it is the clinical ultrasound features of meninges disease. So those are the things that you'll be looking at when you're doing your ultrasound to exclude meninges disease on ultrasound. So now, what are the key leading points from this case presentation? Benign ovarian tumor, most commonly caused by an ovarian fibroma. So we are saying that meninges disease is not a cancer, it's just a benign condition. Can produce marked ascites, frequently cause right-sided pleural effusion. CA125 may be elevated despite benign disease, often mistaken for advanced ovarian cancer. Surgical removal is curative, so it is to be surgically removed. The final ascites and pleural effusion will disappear after surgery. So now, the quiz challenge for you guys. A 57-year-old woman presents with a solid ovarian mass, massive ascites, right pleural effusion, elevated CA125. Histology confirms an ovarian fibroma. What is the most likely diagnosis? A. Ovarian carcinoma. B. Cancer tumor. C. meninges disease. D. tubal ovarian abscess. So our correct answer is C, which is meninges disease. So let me go again on the quiz challenge. A 57-year-old woman presents with solid ovarian mass, massive ascites, right pleural effusion, elevated CA125. Histology later confirms an ovarian fibroma. What is the most likely diagnosis? A. ovarian carcinoma. B. cancer tumor. C. meninges disease. D. tubal ovarian abscess. So the correct answer is C, which is meninges disease. Ladies and gentlemen, I thank you so much. I hope you are learning. I hope learning is taking place. If you have got any contributions, any questions, please just type on the comment section and then we'll respond accordingly. Otherwise, enjoy your learning. Don't forget to subscribe and share the link to our channel. Thank you so much. The missing eye. So the classic ultrasound feature it wasn't in the tumor. So the repairing clinician couldn't find it. He tried to identify the strings to IUCD, and they failed. They couldn't find it. Out of the puzzle, there's the stasis case. So here are the sonography. So you can see here on 3D. So you can see here that is the fundus of the uterus. You can see the IUCD there, and then you can see here. So now, what are the there's a rosa there. That's our uterus there. And then if you look at it here, in this longitudinal section, it appears everything is normal on this case, but everything is normal. Look at this, look at what is going on there. Look at what is going on there. So let's go deeper into the case presentation. So the clinical history: a 34-year-old woman present to the gynecologic clinic, complaining of lower abdominal pain for 3 months, dysmenorrhea, irregular intercourse, missing IUCD strings during self-examination, property in 4 years earlier after a second delivery. She denied fever or heavy vaginal bleeding. The clinician attempted to remove her in the clinic, but the IUCD strings could not be visualized. She was referred to pelvic ultrasound. Ultrasound examination. Trans-abdominal ultrasound, normal size and various uterus. Endometrial thickness 7 millimeters. No intrauterine gestational stage, no fluid was noticed. The IUCD was seen noticing this normal fundal position, transvaginal ultrasound. Careful evaluation demonstrated the horizontal arms of the property were extended in the mechanism of the right uterine fundus. The vertical stem traversed the myometrium. The superior aspect projected beyond the uterine fossa, serosa. No complete extrauterine migration. Small surrounding hypoechoic inflammation noted. Both ovaries normal, no admixture abnormality. So, for best visualization of an IUCD, ability to do a transvaginal ultrasound, so it gives you nicely the position and the demarcation and if there are any inflammatory changes around it. So you know that the transvaginal ultrasound is in terms of the bowel gas and also due to the preparation of the patient, maybe the bladder is not all that full, or some patients can be having discomfort in the bladder when the IUCD is malpositioned. So let's now dwell onto the ultrasound case report. So how do you write the report? Examination, pelvic ultrasound, transvaginal and transabdominal. Findings. This is how you can write a very simple report. Unvetted uterus measuring 8.6 by 4.5 by 5.2 mm. Endometrium measures 7 millimeters. Property IUCD is small position. Look at what is going on. Horizontal arms within the fundal of myometrium. Partial uterine perforation with the extension of the superior stem beyond the serosal surface. So the clinical is no evidence of bowel or bladder involvement. No ovaries, no pelvic perforation noted. So this now the best way of summarizing everything on transvaginal. So you can see the position there. As I said earlier, you can see that the IUCD is perforating the myometrium and is also approaching here the serosal surface of the uterus. So that's how you write a very simple and straightforward report. Unvetted uterus measuring 8.6 by 4.5 by 5.2 centimeters. Ultrasound examination. Endometrium is normal, measuring 7 millimeters thick. The property IUCD is malpositioned. The horizontal arms of the property are embedded within the fundal myometrium. Partial uterine perforation with extension of the superior stem beyond the serosal surface, as indicated already. No evidence of bowel or bladder involvement, no bowel ovaries, no fluid floated in the pouch of WSQD. So now, the impression, Mao no property IUCD with the partial uterine perforation recommend gynecological consultation for hysteroscopic or laparoscopic removal. Ultrasound is the first line imaging modality for evaluating IUCD or the strings or pelvic pain. While CT or MRI is used when considering extra or migration suspected. So surgical removal is generally recommended for operation or migrated to prevent complications. So in a nutshell, this is what you then recommend on your ultrasound report or write your ultrasound report when you see that the property IUCD is malpositioned with IUCD. So the final diagnosis of this case is an embedded malpositioned property IUCD with the partial uterine perforation. So that's how you then give your final diagnosis for your findings like that. So these are straightforward diagnoses where you can confidently give a diagnosis without other issues. So in some cases, you have to give a report and also give differential diagnosis. But there are times during which something is very straightforward. You can see that the IUCD is malpositioned and is perforating the posterior myometrium and approaching the serosa as you saw that. So now, what are the teaching points? No evidence of bowel. So the missing IUCD strings do not always indicate expulsion. So it doesn't necessarily mean that if you miss them, the AUCD is expelled. So it can still be within the uterus, like in this case. So the transvaginal ultrasound is the first imaging investigation. So look carefully for fundal position, symmetry, embedment into the myometrium, partial perforation, and extrauterine migration. So these are the key points that you have to consider when you are doing a pelvic ultrasound scan to localize an IUCD. You must check the fundal position, symmetry, embedment into the myometrium, then the partial perforation and extrauterine migration. Those are very critical. So the complications include infertility, chronic pelvic pain, adhesion, bowel injury, bladder perforation, unintended pregnancy, and then migrated IUCDs may remain asymptomatic for long periods, making imaging crucial when strings are absent or symptoms develop. So you can see the challenges or the complications that you can experience when the IUCD is malpositioned. So you must be very careful so that we have to mitigate against all these type of complications that we can come across. So IUD had disappeared, or so everyone thought. That's what the doctors will be doing because they couldn't localize it. The strings were missing, but ultrasound uncovered a shocking surprise hidden inside the uterine wall. Would you have recognized this life-changing diagnosis if you were doing the sonar yourself? Those are the things that you have to ask yourself. Diagnosis must transform. Diagnosis must assist, must help, must localize. So a patient in your hands must get the best experience, and you must give the correct diagnosis for correct management. If you rush things, you are going to say that the IUCD is in situ or is in the normal position, and then you can miss the diagnosis. So let's just have this interactive quiz. So let's have this question. A patient presents with missing IUCD, strings, and pelvic pain. Ultrasound shows one arm of the copper T embedded within the myometrium, or the stem extends beyond the uterine fundus. What is the diagnosis? What is the most likely diagnosis? A, normally positioned IUCD. So now, what are the things? Partially uterine perforated with embedded IUCD. C, endometrial polyp. D, expelled IUCD. Let me repeat the question for you again. A patient presents with missing IUCD strings. So the transvaginal ultrasound shows one arm of the copper T embedded within the myometrium, while the stem extends beyond the uterine fundus. What is the diagnosis? Normally positioned IUCD. Partial uterine perforation with embedded IUCD. C, endometrial polyp. D, expelled IUCD. The answer is partial uterine perforation with embedded IUCD. Explanation: an embedded IUCD penetrates the myometrium and may partially perforate the uterine wall. It often presents with missing strings, pelvic pain, or abnormal bleeding. The individual requires a specialist removal. Okay, I hope learning is taking place. So now, these are the other positions or extra images for you to use for learning purposes, so that you can actually just visualize or see the IUCDs in different positions. So here you can see here that's your IUCD with some of the reverberation arteries there. So you can see it's in the cervix. So it's the fundus is here. You can see it's here in the cervix. So this one is a malpositioned IUCD located in the cervix. Then you can also see this is the uterus, and you can see this IUCD is perforating the uterus, and then it's also perforating the bowels here. Like this is a very dangerous finding because we've got there are a risk of a bowel perforation there. So you can see it's perforating the uterus, and it's going to the bowels there. Again, this is another. That's the uterus there, that's the endometrium there, that's your cervix, and you can see here your IUCD that is localized or positioned within the cervix. So, ladies and gentlemen, I thank you so much. I hope learning is taking place. Don't forget to subscribe, turn on the notification buttons for more useful academic sessions where we try to simplify ultrasound for the better of everyone, beginner and professional, so that we can improve our practice on a daily basis. Thank you so much. So let's just have this interactive quiz. Here are the answers and explanations to ovarian cyst ultrasound quiz challenge 2. Ultrasound shows one arm of the copper T embedded within the myometrium, or the stem extends beyond. So let's start with question 1. What is the diagnosis? So we had this type of a cyst there, which is anechoic. What is the most likely diagnosis? A. Endometrioma. B. Hemorrhagic ovarian cyst. C. Simple ovarian cyst. And then D. Dermoid cyst. Let me repeat the question for you again. So you can see that this cyst is anechoic. So the answer is C. Simple ovarian cyst. Explanation: a simple ovarian cyst is anechoic, thin smooth walls. Listen here, thin smooth walls, because if the walls are thick, it can also be a corpus luteum cyst. No septations, posterior acoustic enhancement, and no internal vascularity. So these are the characteristic features of a simple ovarian cyst. So those are the things that you have to look into before you just jump. So in this case presentation, I am going to present you with the question number 2 that I have got this lesion that we have here. Then lesion that we have here, I need you to which ovarian cyst typically demonstrates come up with a diagnosis appearance. So you can team up that's the reticular pattern that we are having there. A. Dermoid cyst. B. Para-ovarian cyst. C. Simple cyst. D. Hemorrhagic ovarian cyst. So our answer is D, the hemorrhagic ovarian cyst. So that's a hemorrhagic cyst. The explanation: typical fibindings include reticular or the fishnet lacey fibrin strands. So these are the fibrin strands, the fishnet there, the fishnet there, the fibrin strands from the blood there. That is what. So in this case presentation, fine internal freckles and then no internal blood flow. Good throat transmission. That's why we are using posterior acoustic enhancement there. There's enhancement there posteriorly. So that is the characteristics hemorrhagic ovarian cyst. Come up with a diagnosis. Question number 3. You can the classic ground glass appearance is most characteristics of. So this is the ground glass appearance that we have in this cyst there. This one. The individuals. So I need you to come up with the diagnosis. So write in the comment section. Let's discuss in the comment section. Endometrioma. D. Let's exhaust. Then after so the correct answer I will then give you the answers. So this C, is a new which is an endometrioma wave of quiz. Here's the explanation. Real endometriomas show homogeneous. So I've just done this case today. Echoes. So let's see the images. Then I need you to come up. Then I'll give you the history so after I have shown you the images. Then I need you to come up with the diagnosis or the differentials of what you feel or what you think it is. There's the endometrioma there. So question number 4. Which pathology? So there we go. Of the so what we have here, guys, is the what we have here. We do have got the carotid. This is the carotid. Carotid, the so right carotid artery there. B, then if you look down here, you can see there's a bulb there that is bulging. So the bulb that is bulging there. This is the rocking I hope that you are seeing it. With posterior acoustic shadows there. Down there is a bulge. There's a bulge. There's a bulge. There's a bulge. Explanation: this is the carotid. That's the right carotid. Features, I wanted to look every what is going on here. So I need you guys to start to brainstorm or to guess what the answer could be or what it could be. You have seen this sonographic appearance. You're doing a sonar. So this is the carotid going all the way like that. Question number 5. The base of the carotid. Which cyst demonstrates the classic ring of fire on so I've got so a number the ring of fire that we have images and videos that I have acquired. So in this presentation, I'm just giving you the video so that you can appreciate in real time what was going on. Then you can come up with a diagnosis. So which is the best response there?
Let
which one
me
is the best
go to the
response,
next
which gives us
video,
the
and
ring
you
of
can
fire
see what is going on there.
configuration. Answer is C. This is a corpus luteum cyst. Explanation: corpus luteum cysts typically show thick crenulated
So here
veins,
on color Doppler,
peripheral
let's play color.
hypervascularity, and
Let's
ring of fire
put color there. So you see on
Internal
color Doppler
hemorrhage
there, you
may
can
also
see
be
this is the carotid.
present
Look
within
at
the
what is
corpus
happening there in
luteum
the
cyst.
bulb. There's
So
a
this is a
bulb there,
characteristic
there's a bulge there, there's a
corpus
bulge there.
luteum cyst. The other
Guys,
type
what
of
do you
cyst that
think
can
this
also
is?
resemble a corpus luteum cyst
What
is
do you
a
think this is?
gestational cyst.
Before I
Of
even tell you the
pregnancy,
history, I need
when
you
there is an ectopic
to
ovarian
think
ectopic
of,
pregnancy, it resembles
I
the
need the
cyst.
brains,
But
I
the main
need
difference
the
is
clever
the ectopic
sonographers, I need
pregnancy
the
will be
clever
associated with the positive
radiologists. This
pregnancy
is not
test.
an
At the same time,
examination.
you can see
So
the yolk sac inside or a
let's make
fetal
it
fluid
interactive.
developing inside,
Let us
depending
interact
on the stage of the
come up with
pregnancy.
the possible diagnosis. I need
Question
you
number
to
6.
so this is the most
Which
exciting
feature
part
best
of
differentiates a
our quiz
para-ovarian
session where
cyst?
we do the real.
So A,
And now I'm going to give you
ground
the
glass
real cases that
echoes.
I am doing
B,
at my department. Then
internal
I share with you here.
vascularity.
Then we
C,
discuss and
separate
come
from
up
the
with the
ovary.
diagnosis. Look
D,
at what is
thick
going on there
septations.
in color Doppler. Look.
So our best
What do you
answer
think this
for
is?
this question is separate
What
from
do you
the
think
ovary.
this is? So let's go to the other video, another
Para-ovarian
video again.
cysts are adjacent to but separate from the ovary, usually simple and thin-walled, move independently of the ovary.
Okay.
So that's why it is called a para.
So now,
para means they are running parallel to the ovary.
section, can you see what is going on there?
Within the
Can you see
ovary
what you
itself.
see the
That's
carotid
why
there?
it
The
is
carotid there. Look
para-ovarian
at what is
cyst.
happening there. What is going on there?
Question number 7.
Is this normal?
There we have a cyst again with papillary
If
ectopic
it's
inside.
abnormal,
Then
what is that is abnormal?
internal
If it's
vascularity
normal,
what is
that is normal?
projections.
So
Which
this is the right side of the neck, and you can see here our carotid. What is this and what is going on there?
Thin walls. C,
Okay.
papillary projections with vascularity. D, anechoic fluid. So the best choice for this question is C, which is the papillary projection.
So let me give you another
with vascularity. So the
video
papillary
again.
projections are these ones.
This
the
one
masses that
you
you
see now on color
developing
Doppler, you
inside
can
the
see here,
So
you
for
can
you
see
to
here
make
the
sure that they are
carotid
growing
nicely. You can
masses
see
or
how it
the
is
living
pink color.
tissue,
Look
you have
at
to
that.
Doppler and
Look
then
at
you see
that.
that there's
So
blood flow
initially
inside.
myself, I
Otherwise,
was thinking that there is
hemorrhage, you can
sort of
also,
a shanding that is happening
appear the same,
there.
but
I was thinking that
hemorrhage,
there's an
blood
arterial
clots,
venous shunt
don't
that is
have
happening
blood
there
flow
between
inside.
the carotid and
So the explanation
the jugular vein. So, but on color you can see that these two are distinct.
Papillary projection.
Can you see that? Look at it.
Internal
Look
blood
at it.
flow,
There's a distinction between
thick
these two.
septa and
So what
ascites.
is this,
So
guys?
those are
What
the
are we looking
characteristic
at?
feature of
What
malignancy
is that?
or
I
ovarian
need the
cancer.
brains. I need people who can think.
Question number
Now
8.
view
What
ultrasound.
does a retracting
Hear
plot
me,
usually
people.
indicate?
Radiologists, the clever
dermoid
sonographers,
cyst.
the competent
B,
radiographers. Let's
hemorrhagic
gather here,
ovarian
please,
cyst.
guys. Let's gather
C,
here. What is this?
para-ovarian
What are we
cyst.
looking at?
D,
I've given you a
hydrosalpinge.
hint and a clue. This is a jugular vein,
So
and this is a jugular vein. I think
the
I don't know if it is a
answer,
jugular vein. I am not
you can
sure.
see here,
So
there's
that's up
retracted
to
clot,
up
the
to you
retracted clot that
to
you see
map
there.
what is going on there.
Retracted
If
clot
you
there
are
that
going
you
to say
have
this
there.
configuration
So the
or this
best
morphology
option for
is
this
normal,
is
it's your answer.
D,
If you say there's something
which
that's
is the
abnormal,
hemorrhagic
what is
ovarian
that's
cyst.
abnormal?
Explanation:
You are doing a sonar in your
retraction
department,
clots
then you see this. What is
change
it?
shape over time,
What is that?
leg Doppler flow, and may mimic
Okay.
mural nodules. So you must be very careful when you see this type of a configuration. You might also mistake this for malignant transformation.
Let's play another one.
But
Look
if you
at
put
this.
color Doppler there, you will see
Now
that
look at
there
this.
is no
Look at this.
color flow on Doppler,
Look at
and
this.
at
At
the
the
same
base,
time,
the distal part
they
of the
change
carotid. Look at what is going on there.
So
And then see what is going on there.
clots,
Look
they
at
change
this.
shape
The longitudinal
time
section of the
because it's
carotid
not
as it goes there.
It's only a
Are
clot
you
of blood.
seeing nicely? You guys,
Okay,
look
so
guys.
our
Are
best
you
answer
seeing
for this
nicely? Are you
is
seeing
the
nicely? What is
hemorrhagic
that? What
ovarian
is that?
cyst.
What is that?
Question number 9.
Okay. Let's play another
Follicular
one.
cysts
Another
usually
video.
develop when A, the corpus luteum ruptures. B, a dominant follicle fails to rupture. C, endometriosis develops. D, an ectopic pregnancy.
This is almost the same thing.
Best
This is
answer
almost
for
the
this
same
is a
thing.
dominant
This is the same thing. This is the same
fails
thing.
to rupture.
Look what is
So the
going on.
explanation: follicular cysts are
I
functional
need
cysts,
people who can
thin-walled, anechoic, usually less than 8 centimeters, often resolve spontaneously. So this is a characteristic follicular cyst due to
Let's
a
do this.
dominant follicle that fails to
Look
rupture.
at the jugular.
And they
Look
are
at the
a
jugular.
functional
Look
cyst,
at
a
the
thin-walled,
carotid. Look at.
anechoic, so
I'm
they are
giving you a
benign,
hint, guys. Look
and
at
they
what is
normally
going on
resolve
there. The
spontaneously
longitudinal
on their
section.
own.
What is going on there? This is the
So the
right
last
side
and final
of
question:
of the neck.
which out of one
Look
finding
at that.
raises the Strong suspicion
what is
for
this?
ovarian
Are you
torsion.
seeing? I need you to compare this with the left side, and then you can tell me something.
C. Enlarged ovary with the peripheral
Look what is going
follicles
there.
and
What is
reduced
going on
Doppler
there?
flow.
Are you seeing that? The right side
acoustic
of the neck.
enhancement.
That's what you are seeing, okay?
So the
Let's
best
proceed.
answer for this question is C, which is enlarged ovary with the peripheral
Let's
follicles
proceed. Look at the left side.
reduced Doppler flow. The explanation.
Are you seeing the difference? Or are you seeing that
features
everything is similar?
suggesting
Look at the
torsion are
left side.
1. An enlarged
At
edematic
this
ovary.
point, what is the diagnosis?
2.
If you are the one who's
Peripheral
doing the sonar,
follicles stream
what
of
are you going to say
spheres.
this is?
Then twisted
What is that?
vascular pedicel, which is called the
What is that? The left side is that one.
Then absent or reduced
Are they the
venous
same?
or arterial flow.
If not, what is different?
Flow can sometimes still be present, depending on the magnitude of the torsion, of the twisting of the ovary. So basically, this is the morphology, the configuration that you get.
Now,
in
let's do this
an ovarian torsion. So this brings
in
us
the
to the end
section. You can see
of
there we are
our
going there in
daily
section.
quiz challenge.
There's something that is popping up there. There's something that was popping up there. This one is a college nodule in there.
Knowledge. Don't forget to subscribe, turn on the notification buttons so that when we upload new educational content, you will be notified. Thank you so much. Ovarian cyst ultrasound quiz challenge 2. Welcome everyone. Can you attempt these quiz sessions? This quiz session is got a very rich combination of different ovarian pathologies, ovarian cyst. So you are going to master the different types of pathologies in this session. So this is perfect for classroom teaching or ultrasound revision. So you know the different types of ovarian cysts, but you need to know how they appear like sonographically. So you've got the dermoid cyst, corpus luteum cyst, hemorrhagic ovarian cyst, endometrioid ovarian cyst, mucinous cystadenoma, follicular cyst. So the challenge is you might know the different types of cysts, but you have to know how they appear like sonographically. So let's go straight into our quiz session. Question number 1. What is the most likely diagnosis for this type of a cyst?
Nice. I know you are the one.
A. Endometrioma.
This
B.
one is a college nodule in there.
C. Simple ovarian cyst. D. A dermoid cyst. What name is given to this type of a cyst there? Is it an endometrioma? Is it a hemorrhagic ovarian cyst? Is it a simple ovarian cyst, or is it a dermoid? Question number 2. Look at this type of an ovarian cyst there. Look at that. Look at that. What type of a cyst is that? So what color Doppler, you can see how it appears like. Which ovarian cyst typically demonstrates this appearance? A. A dermoid cyst. B. Para-ovarian cyst. C. Simple cyst. D. Hemorrhagic ovarian cyst. Which is the best option? Which is the best choice in this case? Question number 3. The classic ground glass appearance is most characteristic of, so that's the ground glass appearance there that you're seeing there. A. Corpus luteum. B. Dermoid cyst. C. Endometrioma. D. Hydrosalpinx. Which is the best option there? Corpus luteum, dermoid cyst, endometrioma, or hydrosalpinx? Question number 4. Which pathology commonly described demonstrate the tip of the iceberg sign? Which pathology demonstrate the tip of the iceberg sign? So we have the lesion that we have there, the lesion that we have there. So which is this pathology? A. Endometrioma. B. Hemorrhagic cyst. C. Simple cyst. D. Dermoid cyst. Which is the best option? Look at this lesion nicely. So the idea is for you guys to master the different types of pathologies as much as you can. That's why I am giving you different types and different appearances, sonographic appearances. So what is this? Is this an endometrioma? Is it a hemorrhagic cyst? Is it a simple cyst, or is it a dermoid? Time to reveal the answers for our daily quiz challenge. Relax and enjoy as we give the explanations on a case by case. Question number 1. A 34-year-old woman presents with chronic pelvic pain and infertility. Ultrasound shows enlarged ovary, homogeneous low-level internal echoes, thick walls, no internal vascularity, multiple peripheral follicles. What is the most likely diagnosis? So if we are seeing homogeneous low-level internal echoes, so this is what? A, hemorrhagic cyst. B, endometrioma. C, dermoid cyst. D,
what you are seeing there,
ovarian abscess.
or the other that I.
So the answer here is an endometrioma. A chocolate cyst is the one that shows homogeneous low-level internal echoes. Question number 2. A pelvic mass demonstrates highly echogenic mural nodule, posterior acoustic shadowing, echogenic lines and dots, fat fluid levels. What is the diagnosis? A, serous cyst adenoma. B, dermoid cyst. C, hemorrhagic cyst. And D, endometrioma. This is a pelvic mass with a highly echogenic mural nodule that portrays a posterior acoustic shadows with echogenic lines and dots with the fat fluid levels. So this is a dermoid cyst. So the echogenic mural nodule is the rocking task nodule, and the fat fluid levels, now that's the dermoid mesh. So this is the characteristic tip of the iceberg sign that is being explained there. So our correct answer is B, dermoid. Question number 3. A postmenopausal woman has thick irregular endometrium measuring 16 millimeters. It's a postmenopausal woman. Increased vascularity. Endometrial myometrial junction poorly defined. Most likely diagnosis: A, endometrial hyperplasia. B, endometrial carcinoma. C, endometrial polyp. D, submucosal fibroid. So our keywords there are a thickened endometrium, increased vascularity, then endometrial myometrial junction poorly defined. So this is an invasion, meaning to say that the lesion or the mass is invading the myometrium. So this is in keeping with endometrial carcinoma. That's an endometrial carcinoma. That is the lesion that is got that stubbornness of invading the surrounding tissue, so that you can't distinct nicely the endometrium from the myometrium. So our answer is B. Question number 4. A patient presents with severe acute pelvic pain. Ultrasound demonstrates enlarged ovary 9 centimeters, peripheral follicles, minimum venous flow, no arterial flow, and the Whirlpool sign. What is the likely diagnosis? A, ruptured cyst. B, ovarian torsion. C, pelvic inflammatory disease. D, endometritis. A patient presents with severe acute pelvic pain. Ultrasound demonstrates enlarged ovary 9 centimeters, peripheral follicles, minimum venous flow, no arterial flow, and Whirlpool sign. So the keywords: no arterial flow in the Whirlpool sign. So this is in keeping with ovarian torsion. So the Whirlpool sign is a characteristic sign of ovarian torsion. Question number 5. Ultrasound reveals multiloculated cystic adnexia mass, thick septations, papillary projections, internal vascularity, moderate ascites. What is the most likely diagnosis?
Hello
Ultrasound
everyone,
reveals
this is
most
Dr.
loculated
Sam,
cyst
and today we will learn
adnexal
to
mass,
identify all the
quick
important
septation,
structures seen in
papillary
this
projections,
longitudinal
internal
ultrasound image
vascularity,
of the right
moderate
lobe of the
ascites.
liver and the
What
right
is the most likely
kidney.
diagnosis?
This image is very
A.
commonly
Leucina
taken
cyst
during an
adenoma.
abdominal
B.
ultrasound
Serous
scan,
cyst
so it is
adenoma.
important to know
C.
what each structure
Epithelial
is.
ovarian carcinoma. D.
The
Hydrosalpingo.
topmost layer
So
is
if
the
you
skin.
see an ovarian mass
It has a
that
unix, is
is
portal
multiloculated
veins are surrounded
with the
and
papillary
represent
projections and internal vascularity, these are in keeping with cancerous transformation. This is epithelial ovarian carcinoma, which is C. Mucinous cyst adenoma is benign. You don't see papillary projections. You don't see internal vascularity. Also, serous cyst adenoma
What's up,
is
Ninja Nerds? In
benign.
this video today, we're going to be talking about
Fluid
breast cancer.
contained
Again,
in the
this is a
cyst,
part of our clinical
and then
medicine section. If you
hydrosalpinx.
guys like this video, it
Now,
makes
does
sense, it
fluid
helps you,
collection
please
become
support us. You can do that a couple different ways. Hit the like button, comment down in the
Question
comment
number
section,
6.
subscribe,
A
or
patient
become a premium member on our
presents with
website. We have a link
heavy
down in the description
menstrual
box below.
bleeding.
Go check that out. We have our notes,
Ultrasound demonstrates
illustrations, quiz questions, everything that you
globular
would need to
uterus,
truly succeed in all of your
heterogeneous
courses. All right,
myometrium,
let's get into it. Let's talk about
fan-shaped
the
shadowing,
pathophys of breast cancer. All right, my friends, let's start talking about the
myometrial cyst,
pathophys. When we talk about breast cancer, it's really
thickened
important to
junction
understand that when
What's
you look
the
at the basic
diagnosis?
anatomy of
A.
the breast, that there is,
Fibroids.
all these mammary glands, and
B.
really it's made up of ducts and
Adenomyosis.
lobules.
C.
That's really all it is, and that's what
Endometrial
helps us to
polyps.
make these
D.
the milk, as those cells. That's where
Leiomyosarcoma.
cancer arises. Cancer
The
arises
patient
from those
presents with
lobules or
heavy
from those ducts and
menstrual
from those
bleeding.
epithelial cells.
Ultrasound
They unfortunately
demonstrates
undergo
globular
mutations of sort to
cystus,
become malignant. They start
heterogeneous
to proliferate,
myometrium,
they grow,
fan-shaped
and you get
shadowing,
these clumps of abnormal malignant cells
myometrial cyst,
within the
and
lobules or within the
thickened
ducts, and then
junctional
eventually they can
zone.
spread. That's
So, the globular structured uterus with a heterogeneous myometrium and the fan-shaped shadowing, which we call the Venetian blinds, is a characteristics of adenomyosis. So this is diffuse or global adenomyosis. So with adenomyosis, that's where you see that the myometrium junction is a thickened junctional zone, and then you've got myometrial cyst. So this is in keeping with adenomyosis. Question number 7. Ultrasound demonstrates a tubular cystic structure with incomplete septa, waist sign, the cogwheel appearance, and no internal vascularity. What's the diagnosis? A. Para-ovarian cyst. B. Hydrosalpinx. C. Ovarian cyst. And D. Pyosalpinx. So the incomplete septa with the waist sign and the cogwheel appearance is in keeping with hydrosalpinx. So hydrosalpinx is that's morphology on ultrasound, incomplete septa, waist sign, cogwheel appearance, no internal vascularity. Question number 8. A first trimester pregnancy has empty uterus, adnexial gestational sac, live embryo with cardiac activity, moderate free fluid in the pelvis. A first trimester pregnant woman has empty uterus, adnexial gestational sac, live embryo with cardiac activity, moderate free pelvic fluid. What is the diagnosis? A. Pregnancy of unknown location. B. Heterotopic pregnancy. C. Tubal ectopic pregnancy. D. Corpus luteum. Empty uterus, adnexial gestational sac, live embryo with cardiac activity, moderate free fluid in the pelvic region. So the answer is tubal ectopic pregnancy. A heterotopic pregnancy is a pregnancy where there is coexistence of a normal intrauterine pregnancy and an ectopic pregnancy. So in this case, our uterus is empty, so it can only be tubal ectopic pregnancy. Question number 9. A large uterine mass demonstrates rapid interval growth, irregular margins, marked central vascularity, areas of necrosis. What is the most likely diagnosis? A. Degenerating fibroid. B. Leiomyoma. C. Leiomyosarcoma. D. Adenomyosis. What are the key words? It's a rapid interval growth of the mass, irregular margins, marked central vascularity, and areas of necrosis. So a rapidly growing mass with central vascularity and areas of necrosis is in keeping with leiomyosarcoma. So that is now a cancer. So a fibroid can transform into a cancer. So when that happens, it's now called a leiomyosarcoma. So the correct answer for this question is leiomyosarcoma. Question number 10 in our last question. A woman undergoing infertility woke up with ultrasound findings of 2 separate endometrial cavities, deep external fundal cleft above 1 centimeter, widely divergent uterine horns. What is the most likely diagnosis? A. Septic uterus. B. Arcuate uterus. C. Biconate uterus. D. Diagnose uterus. So the main keywords here are 2 separate endometrial cavities, deep external fundal cleft above 1 centimeter. So there is a deep fundal cleft above 1 centimeter. So this is consistent with a biconate uterus. That's a biconate uterus. Ladies and gentlemen, this marks the end of our expert quiz daily challenge answer and explanation discussion. I hope you are doing very well. Let's meet again tomorrow with the second quiz. Then we can tackle that. Then we'll discuss the answers again. I hope learning is gradually taking place. Enjoy the rest of your day. Don't forget to subscribe to our channel, share, like, and comment. Good day, everyone, and welcome back to Medical Ultrasound Academy. Today's case is one of the rarest and most fascinating conditions ever reported in medical imaging. It is so uncommon that many radiologists, sonographers, and gynecologists may never encounter a single case throughout their entire careers. Imagine a woman who became pregnant, lost the pregnancy decades ago, and unknowingly carried the remains inside the abdomen for more than 35 years. Instead of being expelled or absorbed by the body, the fetus gradually become converted into calcium, creating what is known as lithopedion or the stone baby. At first glance, this patient simply presented with chronic abdominal discomfort and a pelvic mass. However, as the ultrasound probe was placed on the abdomen, an astonishing picture began to emerge. What initially appeared to be a calcified mass slowly revealed recognizable fetal bones, including the skull, the spine, the ribs, the pelvis, and long bones. The ultrasound findings immediately raised one of the most extraordinary differential diagnosis medicine. In today's presentation, I will guide you through this remarkable case step by step. We will review the patient's clinical history, analyze the ultrasound findings in detail, compare them with X-ray, CT, and MRI appearances, discuss the differential diagnosis, explain how the diagnosis was reached, and finish with the key learning points that every ultrasound professional should know. I also have a challenge for you before I reveal the final diagnosis. I want you to carefully study the images and tell me in the comments what you think this lesion is. Could you diagnose this rare condition before seeing the CT scan? Let's find out together. If you are passionate about mastering ultrasound learning from real-world class that sharpen your diagnosis skills, make sure you have subscribed to Medical Ultrasound Academy, turn on notifications, and join our growing community of imaging professionals. So let's go straight into the case. So this is a very fascinating presentation and a very fascinating case that I have never seen before in the history of my career. So fasten your belts and then let's get to business. So this is the case of the week, the babe that turned into stone, which is called the lithopedion. So you can see here, this is a CT image. You can see here, there's the head of the fetus, and you can see here, these are the hands, this is the body, as you can see here in the pelvis of this lady. So you can see after extraction, you can see that these are the human remains. These are the human remains. So this is the hook. A 68-year-old woman presented with abdominal discomfort. What doctor discovered inside the abdomen stunned everyone. She had been carrying a dead fetus for more than 35 years. Look at that. Look at that. So, a lithopedion is a rare medical phenomenon which an unborn fetus dies during an abdominal ectopic pregnancy and it's too large to be reabsorbed by the body, calcifies into a stone baby. So it will calcify into a stone baby. So the clinical case. So a patient, age 68, gravida 5 para 4, chief complaint chronic low abdominal pain, progressive abdominal fullness, occasional constipation, difficult walking due to pelvic discomfort. So the history, the patient reported being pregnant approximately 35 years ago while living in a remote rural area with no access to medical care. So she experienced severe abdominal pain during the second trimester, followed by cesarean section, cessation of fetal movements. She never sought medical attention and believed she had lost the baby. Over her decades, the abdominal swelling remained stable, causing only intermittent discomfort. No vaginal bleeding. Okay, so you can see here on this x-ray what we have here, what we have here. So the examination. Pressure was normal, a fibroid, had irregular pelvic mass, palpable, non-tender, uterus difficult to define separately. So the laboratory test, CBC normal, CRP normal, pregnancy test negative, renal function normal. The ultrasound findings, look at what is here, look at what is here, look at what is there. You can see here the fetal remains, you can see here on x-ray what we have there. So grayscale heterogeneous pelvic mass was noted, dense echogenic structures, multiple fetal long bones identified, well-defined fetal skull, marked posterior acoustic shadowing, no fetal heartbeat was determined, no amniotic fluid, no placental vascularity was noted, Doppler, no internal vascularity, no umbilical cord flow. So the measurements, calcified fetal mass, so approximately 18 by 12 by 10 centimeters. So the pelvic ultrasound reports are clinical indication, the pelvic mass. So findings, a large densely calcified heterogeneous mass is identified within the abdominal cavity. Multiple recognizable fetal skeletal components including the skull, the vertebral column, the ribs, the pelvis, and long bones are visualized. Extensive posterior acoustic shadowing limits complete assessment. No fetal cardiac activity was noted. No abdominal fluid is demonstrated. So the color Doppler demonstrates no vascularity within the lesion. The uterus is displaced but otherwise unremarkable. No free pelvic fluid. So the impression, a large chronic extrauterine calcified fetus which is called the lithopedion. Findings are highly characteristic of an advanced abdominal ectopic pregnancy with a complete fetal calcification. Recommend CT scan for surgical planning. So when you see such a case, you should also recommend the CT so that they can plan for surgical management, and then it can localize it nicely. So these are the stunning x-rays. As you can see here fetus there. So that is how an calcified orthopedion fetus appear like on x-ray. You can see how it appears like on x-ray. It appears exactly like this. So the x-ray shows complete fetal skeleton, calcified skull, vertebral column, femurs, the ribs, abdominal fetal line, abnormal fetal line, dense calcified surrounding the fetus, which the classic diagnosis, what is the, that's a what? That's a what? That's a what? That's a what? Have you ever seen such a case in your life? Have you ever heard about it? Have you read about it? Or it's your first time? I'm asking you, the medical community, the sonographer community, the radiology community. What's your take? Have you ever seen this during your years of experience and work? So here are the CT findings. You can see here what we have there, what we have the calcified lithopedion there. You can see it there, you can see it there. So CT demonstrate completely calcified fetus, preserved fetal anatomy, calcified placenta, no surrounding inflammatory changes noted, displacement of bowel loops, chronic adhesions,
So 3D reconstruction beautifully demonstrated the fetal skeleton. So you can see here on 3D reconstruction, you can see here the fetal skeleton there nicely. MRI. So MRI is really required, but may show sigmoid void from calcification, relationship to bowel adhesions, uterus separated from the fetal mass. So in this case, we don't have the images for the MRI. It was not necessary because we have got all the information that you need. So you know, when you are doing radiology or practicing radiology, you must also appreciate the role of other imaging modalities, and you must know at what extent that some modalities might not be necessary. So in this case, we have made a diagnosis already, so it's not necessary to proceed to CT, which is an unnecessary expense to the patient. So the final diagnosis, that's a lithopedon, which is a stone baby. So it's called a stone baby, a rare complication of an abdominal ectopic pregnancy in which the deceased fetus becomes calcified because it is too large to be reabsorbed by the mother's body. So it remains there for years. So what are the differential diagnoses for a lithopedon? Calcified uterine fibroid, mature cystic ovarian teratoma, calcified ovarian neoplasm, calcified lymph nodes, calcified mesenteric cyst, chronic tubo-ovarian abscess. So the management of a lithopedon. How do we manage a lithopedon? How is it managed? So CT evaluation, multidisciplinary assessment, then conservative management in selected elderly asymptomatic patients. So if someone is old, there's no need to bother them. There's no need for surgical intervention. If there are no symptoms, you can just let it go like that. So laparotomy is if symptomatic or complications develop. So at times it can be associated with pains and all that. So in that case, then you need to relieve the pain from the patient. Then that's where you can operate and remove the lithopedon. So what are the learning points in this case? What are the learning points, the take homes? So lithopedon is extremely rare, estimated incidence around 0.0054% of all pregnancies. It results from abdominal ectopic pregnancy where the fetus dies after the first trimester and cannot be reabsorbed. So the body deposits calcium around the fetus to protect against infection. So you see how the body is good, self-preservatory method. So it disposes calcium around the baby so that it doesn't cause, because the baby is a foreign body, it doesn't cause inflammation around the surrounding tissues. Many patients remain asymptomatic for decades before diagnosis. CT is the best imaging modality for defining anatomy before surgery, while ultrasound is often the first imaging test to raise suspicion. Ladies and gentlemen, this is one of the most fascinating cases ever. I hope or I wish you can see such, or don't miss it in future when you come across a lithopedon. So let it be at the back of your mind that I might meet a lithopedon. I might see a case of a lithopedon when you're scanning these old postmenopausal ladies. Thank you so much for your time, ladies and gentlemen. Let's meet again in the next segment of our case discussions. Thank you so much. Don't forget to like and share. Enjoy the rest of your day. Bye. Ultrasound mystery case. Meninges disease. Is it a benign tumor or is advanced ovarian cancer? What's your take? So these are ultrasound images for a case in question. We have got an ovary here, then we've got a tumor here, there is a mass there, there is a fibroma here in the ovary there, and you can see here there is ascites around the uterus. That's the bladder there. There is ascites there, that's the uterus and the ascites. You can see that the uterus is floating in ascites. And you can see ascites there. Then there, all of that is ascites. So on X-ray, so you can see on X-ray there is pleural effusion there. There is right
pleural effusion, right-sided pleural effusion.